BioBalance Healthcast, episode 119, Gender-Specific Medicine.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Good morning. Today we're going to be talking about gender medicine and gender-specific medicine. As an OBGYN, Kathy spent many, many years working and focusing on and learning about treating women, and got into hormone replacement therapy as a way to treat women who had specific needs and specific issues. And over the time, the men have been knocking on the door saying, wait a minute, it's got to be more than just my wife, and I need some of this too, and can you help me? And so she's gradually had to learn what she's needed to know. But we've been having some conversations about the differences in the way the medical system regards women as opposed to men for considering certain issues, and especially in terms of treatment protocols. And this last week, in the New York Times, there was an article about gender-specific medicine that talks about problems in dosage because women metabolize differently than men. And so the dose of a particular medicine can't be standard across genders.
But it is.
But it is.
But when
it
you
often
read,
is.
Almost every drug has one dose, and it doesn't specify for gender, okay?
Yes.
So when we learn pharmacology, we learn one dose for Prozac, like 20 milligrams, and one dose for Zoloft, and that dose goes for a 90-pound woman to a 300-pound man. Now, I always question this, and basically the pharmacologist that was teaching us basically said, "Shut up and sit down."
This is the way it is. Shut up and take your notes. Exactly.
And it does work that way.
Yeah.
I mean, my husband's a huge guy, and oftentimes antibiotics have to be doubled to really hit him.
Yeah.
So I mean, it's gender specific both ways, men and women.
Right.
And but this article was the first article I've ever seen in common news that said,
Right.
yeah, we have a problem. There's a gender difference, and we need different dosages set up by the FDA for many drugs.
Well, so then they start looking into the history of it. Why did this come to pass, and what can we do about it? Do we need to retest for all the drugs? Do we need to recertify dosages for women? What have you?
Basically, every drug is based on males. So all of the studies are done by males.
And part of the reason for that is
me.
until 1993, women who were fertile, women of childbearing age, were by FDA rule excluded from drug
All
tests.
studies.
Yeah, from all the studies,
Yeah.
because they might be pregnant, that could potentially harm a fetus, they don't want to take the risk, and so until 1993, they weren't even in the test pool.
That's right.
So, any drugs that were established before then are all rated exclusively on males.
And I contend that it's not just gender difference. I think it's gender difference and it's individual. And that's why what I do is individualized medicine. It's 10 times as much testosterone for men as women, because when we were young, that's what we had. So that's how, so it's specific for gender, but then it's specific for how that individual metabolizes.
Right. Yes,
So-
because you talk about the difference between free testosterone and total testosterone.
Right.
On the blood test, when you get the blood test score back, it says your testosterone is elevated to this or that, and doctors who don't know what you know will look at those results and say to their patient, wait a minute, she's got you really out of balance here. Your testosterone is so high, that's a concern. And what you're tracking is the free testosterone.
Free testosterone is the one that matters because it's actually what you use. If the total testosterone is basically the inactive and the active. The inactive is running around in your bloodstream. It's essentially invisible to your body. So it doesn't matter. It's just your storage, and there's nowhere to store hormones. Endocrine hormones, they are stored in the blood, so they have to be inactivated. Well, that's your storage. But women, like if they have a high testosterone total, they have a very small percentage of that that's active. So oftentimes, and as we get older, the percentage gets smaller. So to actually get the active testosterone to be high enough to make a difference, to bring people back to health, you have to make the total testosterone high.
Yeah.
And so doctors just look at that and they freak out. And it's not about that. That doesn't do anything.
Well, and again, because classically what they learned about testosterone, they learned about it for men.
Right.
So they're looking at these volumes of testosterone for men and looking at some little tiny woman and saying, oh my God, there's something wrong here. They don't know what exactly is wrong and they don't know what that would do, but they just know it's not what they learned.
Well, part of what this article talks about is that women have much more subcutaneous fat and fat in our bodies. Like, we float better. I mean, most of us. If you have more bone and muscle, you are denser, you have less fat, and
Right.
men are much denser from the get-go. I mean, from the time they're babies, they come out heavier, denser, and women come out kind of softer, fluffier. So basically, that's the difference. And drugs that are lipophilic, which means they go to the fat and they're stored in the fat.
Right.
Then women need to have more, or they may need to have less, depending on how it's metabolized in the fat. Is it metabolized, concentrated, and released, or is it just sequestered there and stays there? And so you need more so you can get it to all the tissues.
Right.
So that's a difference of a drug's physiology.
When they make a drug, when they make a pill, for instance, like an aspirin as an example, most of an aspirin tablet that you take is sugar. And then the active ingredient is the acetylsalicylic acid. But they have to have a base or a substance to put it on to hold it so they can get into your body, and then that gets metabolized. And drugs traditionally metabolize either to water or fat. And so they're water soluble or fat soluble to be absorbed in the tissue of the body. And so that's what you're talking about with women having more and different fat deposit areas. Then drugs that are fat soluble go to those areas and stay longer in women. It takes longer to get them metabolized out. And those distinctions weren't studied when most of these drugs were
Because
studied
they
for
didn't
human
study
consumption.
women.
Yes, because they didn't study women.
But the group of doctors that call themselves gender-specific physicians are studying. There's a group at Harvard that does this, and they're studying the difference between for every drug.
Right.
And they've had several articles that I'm not going to give you the date now, but because I can't recall it, but where they talked about pain medicine.
Right.
How pain medicine is different for both men and women, and there's certain pain medicines that are better for men and certain pain medicines that are better for women. And I don't have experience with that because
Right.
I didn't operate on men. But I do
But
have
it's important to know what you don't know as a physician. And so then you
Absolutely.
refer to somebody or you go
Right.
somewhere to find out from somebody that does know.
Right. It's very important. But I do know about antidepressants because even though I took care of women for all those years, they would tell me about their husbands. Their husbands are depressed. They're taking this. It doesn't work. They're taking that. It doesn't work. Well, when you look at antidepressants, I can tell you which ones work in men and which I would start men on. You know, in general, I would never start a man on Effexor. It makes them nervous and it doesn't work. I mean, from the outcomes, I can tell you that. I can't tell you exactly why, but they can find that out. They should find that out. It should be part of what we know about a drug. When you look up a drug in the PDR, which is the physician's desk reference, or you can look it up on your phone, you should be able to see exactly how that works and which is better and which is more active. Some blood pressure medicines are better for men than
I love
women.
to hear you say that, and especially in terms of your curiosity to know why.
I always want to know
Because
why.
in my experience, a number of doctors just want to know what they need to know. And what they need to know is you don't give teenagers this drug because it increases the level of, well, that's the cause. But say you don't start men on Effexor, you start them on Luvox or some other thing.
Or
And
Zoloft.
so they need to know, all right, this is what you do, this is where you go first. Because
Right.
that's faster, smoother, and
I don't
move
think
on.
they pay attention to that. They usually just, because they don't really recognize the gender difference. We weren't trained that way.
Yeah.
That's something I learned post-training. So they just look at it and say, I know a lot about Zoloft. I'm putting everybody on Zoloft.
Yeah.
I know a lot about
I've
Cymbalta.
had good
I
experiences with that.
Right, or the drug rep gave me samples. I'm
Well, there is
serious.
that, yeah.
And samples, I mean, for some people who don't have cash to spend on
Yeah.
I don't want to say
or
narcotics,
good insurance.
but yeah, or
So the
good
doctors will give
insurance
them.
for it's like depression.
Yeah.
Some of those drugs are very expensive, and so they'll give samples to people who really need it,
Right.
or people who want to try it, because some people can tell in one pill that it is not for them. You know, if it makes them sleep all day, or if it makes them eat all day. I won't take Medrol dose packs.
Yeah.
I just won't do it. I mean, you'd have to hold me down and give me a shot of steroid if you wanted to do that to me, because the first pill on a Medrol dose pack, I go to the refrigerator and I eat anything that doesn't have something green on it. I mean, anything. And I'm hungry all the time, and I just blow up.
So your body metabolizes or responds to that differently?
A lot differently than most people.
Yeah.
And that's an individual difference.
Okay.
That doesn't mean it's all women, but I think it has a lot to do with it being lipophilic. And men do great on Medrol dose packs in general.
Yeah.
They usually don't have a problem. They feel good on it. Most women are hungry and swollen and bloated, and it's miserable, and there's something about the way it's metabolized. I don't understand the difference. I just understand that it is something that I see a lot in my patients, as well as myself. Sometimes we have to go by what we know. We can't find an answer to everything in medicine, because if they don't consider the problem, there's no answer.
Well, and for you men who are out there feeling smug because you don't have all the fat deposits, you need to know that the brain is primarily fat soluble. So when they say you fathead, they literally mean you got fat in your head.
So, and that's also why I'm not really a fan of most cholesterol drugs, because you need cholesterol for your brain. And you need eggs, by the way. So you need to be eating the yellow of that egg, because they just took it off the do not do list this week. It was in the New York Times when we were flying back from New York at the publishers. It was in the New York Times, and it's a little tiny article. You know, the big article years ago was, do not eat the yellow of the eggs, it's going to kill you. And now they said, it's really good for you, and you can't repair your brain without the yellow center. That's stuff that makes your brain, it is what it's made out of. You need that.
Yeah, cholesterol in your diet doesn't correlate to cholesterol in your bloodstream.
Not necessarily. And if it's used to repair your brain, then it's out of your bloodstream because it's being used.
Right.
But cholesterol is really, in many ways, good for you, and eggs are the perfect food because the whites balance the yellows. So you should eat it all together. Anyway, that has to do with
So in this article,
difference.
there's a paragraph or two that just really popped for me.
Sorry about being tangential.
I'd like to read this one and see
Okay.
what your response is. It says, because so many drugs were tested mostly or exclusively in men, scientists may know little about their effects on women until they reach the market. A Government Accountability Office study found that 8 out of 10 drugs removed from the market between 1997 and 2000 posed significantly greater health risks to women. So they test them, they do well with men, they test them on men, they do well with men, they put them on the market, and then there are significant adverse reactions to women that are given those drugs at those prescription levels, and then they pull them off the market.
I've got a problem with that too.
Okay.
I've got a problem with, if you have a great drug and it's given by a doctor, people can't just go self-medicate. You have a great drug for men, and it shouldn't be used in women. Why do you not just keep it for men? Why can't it be that men can take this and leave it on the market? I don't get that part.
Right.
Why can't we just, doc, that's what we're supposed to know.
Okay, so sometimes they seem to do that. I was watching television last night, and I noticed, because of what we talk about all the time, a commercial for Androgel. And I want you to talk about gels in just a minute. But there were all these beautiful little scenes of happy people next to the stream and throwing
Androgel
footballs.
is testosterone for men.
But then it says, warning, across the screen, women and children should not come in contact with this. If you have it on your skin, don't let them touch that part of your skin until it's all absorbed. And it's like, alert, women and children shouldn't do this because of adverse effects.
But it's not.
All the guys need to have it, apparently.
Apparently.
Yeah.
But it's not women and children, because women who are no longer fertile don't have a problem with it. We would use the same drug. It's really, they didn't, there's so many ways they don't get specific enough about telling us about things. So they say, women and children. So my patients come in and say, they're taking testosterone in pellet form. I rubbed against my husband's Androgel. Oh my gosh, what's going to happen to me? Am I going to grow another ear? Or, am I going to get a beard? And I'm like, you're already on testosterone and you're menopausal. So there's nothing that's going to happen to you. That warning is for fertility, for pregnancy. So the only way it's a problem is if you get pregnant and you get it on you. If it's a girl baby, it could be androgenized, meaning look more male or have an enlarged clitoris, which is not good.
Okay.
But I mean, not.
So is the same thing true for drugs like Flomax? When you see the warnings on those that women shouldn't handle these drugs or touch these drugs, is that for women of childbearing age?
That's women of childbearing age. That has
Okay.
nothing to do with menopausal women or women who are postmenopause.
Because men get Flomax to reduce issues with prostate
Right.
and frequency of urination, all that sort of thing.
Well, that's like androgel's testosterone. So we don't want to take a person who might get pregnant. We don't want to give her too much testosterone, especially if she might be early pregnant with a baby that's a girl. Could make it look like a boy. But the opposite is on the Flomax. Flomax has to do with blocking the conversion of testosterone. Actually, I think there's a different drug that's Flomax is a little different, but
has a
some of
different
these
name.
drugs like Proscar
Yeah.
is really interesting because they say don't take this if you're a female. Well, what Proscar does is it stops the conversion of testosterone into dihydrotestosterone, which then causes acne and hair loss in men and facial hair in women, and men usually use it for their prostate to get them to get it to shrink. So it's an enzyme blocker. It's not testosterone like androgel is.
Yeah.
So it's a different reason. In this case, if you took this and you were pregnant and you had a boy child, he would then look like a girl because it would block DHT, which makes them male.
Right.
So it's a different reason, but it's not all women because I write finasteride or same as Proscar in a different dose for women. And it's the same as Propecia too. That's the same real drug, the same generic as Propecia and Proscar are the same thing. But there's two Propecias. Propecia there's a 5 milligram and a 1 milligram. The 5 milligram is for men, and they have a generic, and it is very cheap. The women, however, have a 1 milligram, that's good. They have a dosing difference,
Right.
and that makes sense, but it's like 3 or 4 times as expensive, and it's only brand. So I take finasteride for men and have people cut it up and take half every other day or every third day.
Right.
That's as good as I can do with that because it's silly to spend 3 times as much
Yes.
for the same medication. But that's a way of getting around the system. But for that drug, for Propecia, they actually did a gender difference, and
Right.
it's a gender dosage difference.
But the cost differential is significant.
Yeah, so your doctor has to look at everything.
Right. Well, and I listen to you talk about this stuff, and I know that the drugs you're talking about are prescription drugs that you need a physician involved in.
And the physician
to
should
get.
know how they work if
And
they're going to write
the
them.
physician should know how they work. But in the United States, at least in our culture, we are so mass marketed for over-the-counter medicines and
we
quote
are.
natural medicines, GNC kinds of ginkgo biloba and Beano and garlic breath. And,
That's because those won't hurt you.
well, that's what I was going to ask.
Basically,
St. John's
those
wort
are
and-
either at a dose that won't hurt you, or they're a medication, a supplement that won't hurt you. So they can be over the counter. That's why things are over the counter or
But
not.
we've done podcasts in the past about people who take a lot of these things and they get them from China or they get them from somewhere because they're into organic stuff and not taking drugs and natural herbs and preservatives and so on. And that compounds the problem of metabolic response to other medicines.
Right, and people
So-
don't tell me all the things they're on.
And you have to play chemistry set
Right.
to try to say, all right, well, if we modify
and
this.
we don't,
or-
and doctors aren't trained to know what herbs do. And herbs are just less dangerous and
Natural
less
remedies,
less
homeopathic
strong medicine.
Yeah.
Basically, we find a lot of our drugs from herbs, and then we make them synthetic, and then of course take out the good stuff, and then we give them to people
Right.
as a medication. That's often how there's kind of nothing new under the sun kind of thing.
Right.
So that's often how we find our best drugs is what the herb did it. But over-the-counter medications are always dosed very low. Sometimes that means they are not going to work. That doesn't mean I want you to double your dose. It just means they have to dose them low just in case you double it. So
Right.
it may not be as effective, especially if you're a bigger
Right.
person. And then they also don't give you all of the risks and the things you shouldn't take with it. Now, if you're going to medicate yourself with that kind of stuff and you're already on medication, then knowing the interactions is very important. And here you are, you're in charge of your own health care by doing that. I don't say you shouldn't take supplements because I recommend them all the time, but you should at least understand what they do. And there are books about them that you can look up and see what they're effective for, what they're not effective for. I mean, I have 2 in my office that I use as reference.
And I'm sure there are internet apps that you can download that'll cover that stuff too. Some drugs start, though, as prescription meds and then roll off and become over-the-counter drugs.
Yes, they do.
And do they lower the dosage
Yes.
then when they make it over-the-counter?
Yes.
Okay.
There was naproxen, and now there's Aleve.
Right.
And naproxen was a
Or
much higher
Triminic
dose.
at one time was an over-the-counter dose.
But there's never, they never make something in the U.S. There is never an over-the-counter medication that is habit forming. That's one of the ways they say, oh, we're not doing that. There's never a controlled substance in them. It's always something that is much more benign, and you can't get hooked on them.
Okay, so we're kind of free-ranging here, talking about drugs and medicines and dosages for men and women and the differences. I want to wrap this up today with a reference more specifically to women in terms of the whole question about hormone replacement therapy and whether it's healthy and whether it's good and whether you should be concerned and talk to your doctor about it, all those kind of things. The American Endocrine Society has just released a statement.
Which I'm a member of.
You're a member of. And talk about their statement, because it has to do with the whole question of doctors and women evaluating whether or not they need to replace their hormones after they've gone through menopause. And generally when you see stuff in the media about hormone replacement, it's always about estrogen, because they still don't seem to know women need testosterone.
Right. So it's about estrogen plus or minus progesterone.
Okay.
Okay, so it could mean estrogen alone or estrogen and progesterone. Estrogen, of course, is, we've talked about before, alone should be given only to people who have no uterus, who have had a hysterectomy. But what the Endocrine Society seems to know that the OBGYN group doesn't know, like the American College of OBGYN, has a completely different statement.
Right.
Okay? So what they know in the Endocrine Society is that in certain forms and in certain circumstances, estrogen replacement should be given, and that circumstance is, do you have symptoms? So basically, most doctors wouldn't give you a drug if you didn't have symptoms, and and the way they take out the estrogen and progesterone is, don't use it if you don't have symptoms. Don't use it just for prevention. And I agree with that. I mean, if you feel great and you don't have hot flashes and you don't have a dry vagina and you don't have fatigue and you haven't gained 20 pounds, or some, if you don't have all those symptoms, don't go to the doctor to be treated preventively. That doesn't make sense. And they're using, interestingly enough, doctors who don't check levels.
Right.
So they wrote this for people who are just going by, do you have symptoms, yes or no? And they're not going to draw blood, usually for female hormones. So they're saying, if you don't have symptoms, don't take anything. But if you do have symptoms, take it.
Well,
and it doesn't have a limit on time.
This particular endorsement was included in October of 2012, at the end of last year. The United States Preventative Services Task Force was making recommendations to physicians about preventative medicine and the kind of things that they recommend as preventative medicine. And what's important here is the Endocrine Society is starting to come out and challenge the Women's Health Initiative study that all the doctors read and said, oh my God, don't do hormone replacement therapy for women that are postmenopausal. And this is saying, women should actually look at that if they have these symptoms.
This is in direct opposition to that study.
Exactly, and they ought to consider hormone replacement therapy, meaning replace their estrogen, if they're having these postmenopausal symptoms.
Absolutely, and that it's safe in the way it's given. They also state that you should take it as early as possible after menopause.
Right.
And we've known that because the first 10 years help you prevent Alzheimer's and help you prevent osteoporosis, and you don't have to take other drugs. So we've known all this, but now there's a statement that says this. The catch is endocrinologists don't usually take care of women in menopause. So they have this great statement that actually rings true that I agree with.
Right.
And they're talking to doctors who don't write estrogen and progesterone for patients.
And the OBGYN
And the OBGYNs who
group
do
is still not
are still
on board with this.
They're still in the last century. So, I mean, how do you
So hurry up.
Yeah, so really hurry up. Your members are still refusing patients with hormonal symptoms. They're refusing to treat them. It's very sad. They come to my office and they've been been to lots of doctors first.
Yes. So be an informed consumer. Talk to your doctor, talk to your healthcare provider about what your concerns are, what your symptoms are, but have a knowledge base and continue to read and think about and make decisions that participate in good healthcare for you.
And look up the New York Times article. It was yesterday. So look at yesterday's New York Times.
January
and
29th.
29th,
Yeah.
right?
New York Times.
Yesterday.
Mhm.
So, and read it for yourself. I mean, I think it is poignant into what we do with compounding, because compounding means giving you the dose you need,
Right.
not the dose that everybody takes, every shape, size, and metabolism.
And there's a whole nother level of this conversation that we need to have, and maybe a future podcast. When you talk about gender differences in medicine, you also then start to talk about, especially as the population bubble ages, elder care, and the fact that as we age, our metabolisms change, and so dosages for older people also have to be adjusted.
They actually have those in the PDR.
Yeah.
They have
Recommendations.
for older people because of slow kidney and liver function. So they've covered that.
But again, they're not factored for gender differences.
That's right, and they're not factored for gender.
Exactly. So,
We'll see you next time.
all right, thank you.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. Follow Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth. Brett Newcomb can be found at brettnewcomb.com.